very, very important and essential in palliative care. Not even in palliative care, but when it comes to healthcare settings. So let me share the screen with you. Let me know if you're able to share it. Send a request. Uh, are we audible? Can somebody respond?
Yes, I can hear you, but softly.
What about now? Is it clear? Audible? Yes. It's
Yeah,
clear. Right?
now it's better.
All right, all right. Thank you. So I was talking about, I was wishing you all good evening. And I know this is post lunch. I would be very sleepy, but I'm sure that this is going to be a very important and essential topic when it comes to palliative care, breaking the bad news. So, and this is also one of the most emotional part of dealing with palliative care patients. So let me share the screen with you all. Yes. Can you see the screen? Is it clear? Great, great. So this is also going to be an interactive session. As we had a communication part one in day before yesterday, hopefully yes, day before yesterday we had communication part one where we discussed about what is the importance of communicating, right, and how it will help the patients and their family members, their caregivers, and how they can plan their future and how it efficiently and effectively help them in dealing with their future plannings and everything. So today we are going to see a very important session on how to break the bad news. So is it like we all like to hear the bad news? No, right? We always want to hear happy news. We always want to hear positive things. But we nobody wants to hear about bad news. But and this is going to be one of the most difficult, but have to deal it with utmost care. And today we are going to see it's not like, we tell them directly that this is the case. You will be wondering how would we say, is there any way of telling the patient or the caregivers that this is what the patient's condition or this is what the diagnosis, this is what the prognosis. But there is always a way how you communicate, like we discussed in the last session. Communication is so important. If my communication is not so clear or if it is very boring, then you would not prefer to be in my session, right? So it is my responsibility that I make it sure that my communication is well clear to you, because I want all of you to be very interactive in my session. So it's up to me, right? It's up to me whether how I communicate with you all. So I, especially it's post lunch. So if I be very laggy, if I be very shabby, it would definitely affect you as well because you'll be having your lunch and you're sleepy. Plus, if the communicating, whoever is the communicator, if the communication is not clear, it would definitely be a big problem. Yes. So let's talk about how do we, because the most important part is when patients come to us, the most commonly seen incident in our case or in my case when I deal with my patients, they usually come and tell me, the doctor at so and so hospital, they directly told me that you have cancer and there's nothing can be done. And even the most interesting part is, at the same time, the most saddest part is, we also hear people saying they said it very rudely, and they even compare it to other people, the other patients. Okay, look at this patient. The patient is also going through the same situation as yours, you know. And there is a way always, and we know the fact that it's where we put ourselves in other people's shoes or the patient's shoes. What if it was us? If we are about to hear a bad news, we don't want someone to randomly come and tell me that, oh, you have cancer and it's the end stage, there's nothing to do. We don't want that, right? So there is always a way how we communicate the bad news to your patient. And this session is really going to help you in your future career, wherever that you work in the healthcare system. If you are working in a hospital, not just palliative care, but if you are working in a hospital, it is going to help you, especially when you work in ICUs, in CCUs, when you work in the intensive care units, anywhere. This is going to help you because anywhere at some point of your time, as a nurse, as a doctor, as a social worker, you will be responsible to tell the family members about the prognosis, the end stage of a patient. Now, you should know how you communicate. And we don't want people to come and tell us that, oh, that doctor or that nurse, that healthcare provider told me very rudely about our prognosis. How are we able to handle it? That's the saddest part, right? So let's see how we do it. And there is a process that how we do it systematically, professionally. Now, what we are going to cover today is communicating bad news. How are we going to communicate the bad news? The disclosure models, conflict with patient's rights, rationale for breaking bad news to the patient, collusion management. How to communicate the bad news, communicating bad news, the spikes protocol, case study, role play, anchor management. These are the things that we're going to do today. Since we have very limited time and we also have a case presentation in the end, towards the end of the session, we're not going to role play, but maybe sometime later when we all come to Pallium someday, hopefully, that time we'll have a role play and more of, virtual things. So let's start with a quote that Plato said, "No one is more hated than he who speaks the truth." Right? This is a common scenario in our daily world. When you tell the truth, people don't like it. People want you to lie, right? The hardest thing is to say the truth. When you say the truth, if for example, if I don't like, I'm so sorry, Arya, I like her so much. She's my colleague, she's helping me with a lot of things. But let's say I don't like her. Okay, that's not the truth, but this is an example. If I don't like her, being a truthful person, if I tell her on her face that, Arya, I don't like you, would you like that? No, right? You don't like, but I'm being very truthful. I don't like you. I don't want to work with you. So I'm being very truthful. But she doesn't want that. She doesn't want to know the truth because that hurts at most of the time. The truth hurts most of the time. So we want people to lie to you. Even if someone doesn't love you back, you still want that person to tell you that he or she loves you because the truth hurts after all, right? Now it's the same case here. The truth is maybe the patient is going to die or the patient has very few days left. But they don't want to know. They don't want to know that my father, my mother, my husband, my wife, my children, whoever, my relative, my friend, they're going to die in a few days. I don't want to hear that. But that is the truth. That truth, by communicating it, is going to help them only, right? So this is what we are going to say. Let's talk about the non-disclosure model. Now imagine that you're the doctor or you are the just okay, you're the doctor or you're the nurse, you're the social worker, whoever is a palliative care worker. Now you tell there are few type of doctors or few type of healthcare providers who think that I do not tell bad news to my patients. Why? Let them enjoy their life while they can. Besides, I'm such a kind-hearted doctor. Do you think that please use the chat box if you don't really want to talk? Do you really think that it is going to make you a kind-hearted doctor or it is going to make you a kind-hearted nurse or a kind-hearted social worker if you do not tell bad news to your patient? If you think that let them enjoy their life, does that actually going to make you a kind-hearted doctor, a kind-hearted healthcare provider? No, no, we're not helping them. We are about to help them. We're supposed to help them. That is not going to make you a kind-hearted doctor. Never. It is not going to make you a kind-hearted doctor. Maybe you think because of your kind heart, you think it's like, okay, if I go and tell them about the truth, the patient is going to cry, they're going to get hurt, the caregiver is going to get hurt. So why not they enjoy their life? They can, but no. If they really want to enjoy their life and plan, we have to communicate, right? So this is a non-disclosure model. Some doctors, sadly, they do it. They don't tell purposefully. It still happens in our medical field, but we don't want to happen that. And that's why we are spreading it all over. What is the right way of communicating it to the patient and the family members. Now let's see the conflict. What will happen here if you say you are a kind-hearted doctor, so I'm not going to tell. Maybe the patient sitting opposite to you or the family member sitting opposite to you, they actually wants to know maybe. We don't know, right? We don't know about that. So the patient might say, hey, I want to know what's wrong with me. I cannot live in suspended animation. I have things to do with my life. Of course, right? Because you never know who is sitting opposite to you, right? You never know who is sitting opposite to you. You don't know what is the patient's or the family member's perception about whether they want to know, whether they don't want to know, whether they just want to know the basic things. So if you think that you want to be a kind-hearted doctor, and if you don't say it, then maybe the patient wants to know. It is a right to know. Patient has the right to know their diagnosis and prognosis. Now, so this is a conflict that might happen if you think you are a kind-hearted doctor and you go for a non-disclosure model. Now, when you go for a full disclosure model, I truthfully tell all patients about their bad diagnosis. It is their right to know. It will give them time to plan ahead, which is right. Which is, yes, what is saying here is right. It is their right to know. So, it will, yeah, this is true that it will give them time to plan ahead. But making it a stubborn decision that I will tell my all patients about their bad diagnosis, is it okay? Even if they don't want to know. Is it? No. Because you never know what the patient decision is. Whether the patient wants to know or the patient doesn't want to know or the family members don't want to know. Right? So even what the conflict that might happen in the full disclosure model is patient has right not to know. Yes, it is also patient's right not to know. I don't want to know what's wrong with me. Just leave me alone. Let me be in peace. What if the patient says that and you still wants to tell the patient, you're putting them in trouble. But there is always a way, a very slow process where you eventually make the family understand the situation without hurting them so much. Even if they get hurt, yes, telling the truth is going to hurt, but during the time you're there. You palliative care workers are there with them. That is why we are here, right? To help them. Are we your presence? So let's talk about the individualized disclosure model. Let me find out if the patient wants to know or not. And if the patient wants to know, let me figure out how much. How many of you think, you can raise your hand, how many of you think that individualized disclosure model is the perfect one? This is what we need to follow in palliative care. Yes. What happens if the patient does not want to know, but the family wants to know? We're going to come in that. We'll be discussing about it. Yes. Yes, Ernestina, we'll be discussing about that. Okay. Yeah, because I have asked them to raise their hands if they think this is the perfect way of disclosing it. Individualized disclosure model. First thing is that you have to find out. You have to find out if the patient wants to know or not. And if the patient wants to know, let us figure out how much they wants to know. And as Ernestina asked, whether only the patient does not want to know, whether the family only wants to know. Now, why do we communicate bad news? So these are the points. Closure of life business, which means it will help them to settle some finances. There will be last will. Okay, let me write this much land or this much money into my children. Let me divide it into to my children, my family members. There'll be a will. And that's account password because you never know how much money you have in your account. You never know because we don't tell other people, even to our children, about the password of our bank accounts, right? So this can help plan to tell them or share the details of their bank accounts and everything so that the next nominee or whoever is the next person can take care of all the expenses. Now, settling children's education, marriage, etc. See, there would be their wish, they have put it in the bucket list. Like, okay, let me, in this time period, let me give this education to my children. or maybe let my, I want my girl or my son to get married in this time. Maybe this will help. Knowing their prognosis, knowing their worsening of their health, maybe they can postpone it a little earlier. They can plan it wisely and accordingly so that even before they die, they will get a chance to see their marriage, or just they can find out solutions to settle the children's education as well. Yeah. Bucket list and memories. Even I have so much of my bucket list where I want to go to different places. I want to explore. So they will also have some bucket list and memories. Relationships, a time to say I love you and goodbye. Obviously, we are family, we have relatives, we are a relationship, and obviously there would be scratches and hostilities and everything, mentions inside the family members, which is very common, right? Now, in this time, maybe we give them a chance by communicating it. We give them a chance to make it all better. Maybe they can recreate their friendship or reconsider the relationships and say, I love you, say, I forgive you, say goodbye, or ask for forgiveness to be asked for and given to. We're actually creating a space for the patients and the family members, exactly for the patient to do all this. It helps the patients. Now, hospital hopping and doctor shopping, very, very, very important. We see a lot of patients coming here selling all their lands for unnecessary medicines, expensive medicines, without knowing. We see many people selling their land, their money, they become in a huge debt. They fall into the trap of huge debt by listening to the doctor saying, especially when it comes to private hospitals, go for unnecessary surgery. Because when you do a surgery, when you go for an expensive treatment, it is important that you make sure it gives you a positive result. It gives them a positive response. There should be a cure to the disease. If there is no cure to the disease, why do you want to go for it? Why do you want to waste your money? Why do you want to waste your resources on that? The expectation versus reality mismatch. So by communicating the bad news, they might be thinking, okay, she has more life to live, so that there's more to do. Okay, why don't we take her to the topmost private hospital that where she or where he can get the best treatment? Their expectation might be like this. But when we understand as a palliative care health worker, we can help them correct their misconception about it so that they don't waste their resources on such surgeries, on such treatments. Maybe the last few days we need to consider bringing up the quality of life of the patient, not to lose their or spend their resources that they have. Maybe all they have would be a land, all they have would be some money or savings in their account. But what about the other family members? What about the children? What about the wife? Or what about the husband? They need to live, right? So if they spend all these resources on an unnecessary treatment which does not cure the disease, this is a waste of time, waste of resources. By communicating bad news, we can do that. We can help them understand what is the actual prognosis and what they need to do. Pursuing futile or non-existent remedies. So they might go for other remedies. We know certain proxies who would come, husbands, they've come to us and says like, oh, these RCC, the cancer center cannot do anything. They said there's nothing can be done. But when I communicated with one of my friends, he told me that one of the other Ayurveda doctor who works with him can actually cure this. They give a completely wrong thing, a misconception about it. They give a hope that it can be cured when it is actually not. So they have traveled 24 hours from here. 24 hours. It takes one whole day to reach to that place. And they have literally traveled from here to there, spending their money for the treatment, which did not cure the disease. The patient has already died. Now we can help in this case. How? By communicating the bad news properly. Wastage of precious time, health, and resources is what we were talking about. So this is why we communicate bad news. I hope it's all clear. Let me know if you don't understand anything. You can use the chat box and ask, or you can raise your hand. Okay. Now, Also, why do we communicate the bad news? Because there are barriers in relationships. Wasting precious time in pretending normalcy. You don't have to pretend normal and be sure that you're okay. Because we need to understand what you're going through. We need to be there to help you with your distress, with your difficulties. Wasting opportunity for strengthening relationships. Wasted opportunity to mend relationships. That's what we talked about before. Being accused of not caring enough. Being accused of ulterior motives is not caring enough. Painful memories. In this way, also, we communicate bad news. This all helps. Communicating bad news, in fact, only help majority of the patients and the family members. But there are few exceptions. There are few exceptions which we will discuss towards the end of the session, including Ernestina's request on. She also had a question. Yes, we'll be discussing about that towards the end of the session. Now, collusion. What is collusion? A conspiracy of silence. A collusion is an agreement between you, the healthcare providers, and the family members. So, suppose if the family member comes and tell you, please don't tell my father about his disease, he doesn't know about it. Let's take cancer, because cancer is what we mostly encounter with, right? Cancer patients. They'll be having a diagnosis, they'll also have a prognosis. In some cases, the patient might not know the diagnosis as well as the prognosis. But some other cases, the patient knows the diagnosis, but he doesn't or she doesn't know the prognosis. In some rare cases, nobody knows about nothing. How do we handle that? There are situations like this. So the initial thing when you attend a patient or a family member having an end of life care, or maybe who's in advanced cancer stage or advanced, or maybe they're fighting towards the end of life, if you understand that, make sure that whoever is the person sitting in front of you, that can be a family member, a son, a daughter, a relative, husband, wife, whoever, or a patient, make sure that do not talk directly to the patient. Because the first thing is that we need to know whether the patient knows or not. If the patient doesn't know, why he doesn't know? If he doesn't want to know, or if the family member is pressurizing not to tell the patient, but the patient wants to know, or if there is some other health issues like cardiac issues or anything, which if we tell in some way, it might affect him physically. He might go for an arrest, cardiac arrest. So we need to look into the all possibilities. So that is why this area where we break the bad news is very, very sensitive. But at the same time, it is the most difficult also. But this is an art. Breaking the bad news is an art of doing it. You should be well planned. You will be having all the knowledge to know how to do it. Now, the collusion is an agreement. For example, if it is Arya or me, let's say Arya's patient. Arya does not want Arya is coming and telling me, doctor or nurse or sister, whoever, please don't tell my relative that he or she is having cancer. He doesn't know. So the first thing as a healthcare provider, as a palliative care provider, you should understand why. You should also understand whether the family members knows. If the family members does not know, you have to tell them anyways, because at least one of the family members should know what is the diagnosis or the prognosis. So there's a way how you tell it, which we will see in the coming slides. And then you understand why the patient does not know. So the family member or the proxy might tell you different reasons. Sometimes they itself don't want us to tell the patient about the prognosis or the diagnosis, because they prefer, let my father be happy, let my mother be happy. But we don't say okay, but we make sure that we explain them why it is the right of the patient to know the diagnosis and the prognosis. Let's see. Family is trying to protect their loved ones. Very clear. We can't blame, right? We cannot blame. If it was us, we would think that why do I have to tell this to my parents or to my husband or my wife or my children? Let them enjoy it. If they come to know, they'll get hurt only. But they do not know the other side of the story, the flip side of the story. Now, you as a healthcare provider should tell them and explain what is the other side of the story? What are the positive things if we tell them? Now they will get a clarity on that. Now you are helping them to think and take a wise decision. Do not challenge their belief. They will be having different beliefs. So respect individuals, respect all the family members. Make sure that you do not challenge their belief. Their belief systems would be different. It might collide with your belief system. But as we said, the spiritual factor is different. The spiritual factor is individual. My spirituality won't be the same as your spirituality, right? Or maybe Arya's spirituality. So this is how the world works. So you cannot challenge their belief. Agree to collude. Okay? But you should know the reasons and you should tell them. You are agreeing to, okay, we are not telling you or we're not telling her about the diagnosis or the prognosis, but it is important that they should know the other side of the story. On the family stress first. That is the first thing that we need to do. Listen to the family and understand what they go through and understand why they're telling not to tell the patient. Build a relationship with them. The more you build a relationship, they will be at some point of time. This has happened with me many times. After building a rapport, after relieving the patient's suffering, and after acknowledging their pain, and after explaining them the flip side of the story, they have agreed to. Okay, I think it is. They have flipped their decision. They have changed their decision. Right. But it is the patient who is suffering. Yes. Right. So it is the patient, we might. I'm sorry. I just saw the chat and I have put. Okay, Ernestina, can you make it a little more clearer, like what you meant by that? As a patient who's suffering.
Thank you. Thank you. You were saying that we should listen to the family
Right.
because they know what they are going through, and that's why they are colluding with you. But I'm also, my question is the patient who is also suffering or who is in pain, who is going through the discomfort?
Yes.
So if the patient wants to know and the family wants to protect the patient from knowing.
Yeah, so you're asking me if the family does not want
Yes.
to know, but the patient
Yes.
wants to know.
They don't want you to tell the patient,
Right.
but the patient also wants to know.
Right. So that is where how we are going to apply this. In the coming slides, yeah, I will explain to your answer. Okay, I think that is where we're
Thank
coming.
you.
Yes, yes. Right. So this is a very, very valid question, and it usually happens at here with me. When the family members come and they say, please don't tell. But when we start talking to the patient will ask us, tell me what is my issue, what is the actual physical concern. You can be open, you can tell me. Sometimes the patient will be very positive. And they also have told me many times that my son, my children, they're very scared of how I might react. But it's okay, I can say. Now, we will be having a proper communication with both the family members and the patient. And then once the patient wants to know, the patient's right to know is the patient right to know itself. And there's nothing more than that. If the patient wants to know, yes, we need to reveal it. And we'll be communicating that politely with the family. And we'll be telling them we talk to the patient, and the patient wants to know. And eventually, usually, what happens is that family will, accept it, because that's a miscommunication happens there. There might not be a proper communication between the family members and the patient. Maybe that is why the family thinks that, okay, I don't want my father or mother to know about it, but the family, the patient really wants to know, but the patient is not able to ask the family members, because the patient thinks it will hurt the family members, the son or daughter. They think that it's going to hurt the patient. Now, that is where we work in between as a mediator, and we help them both to come together and take a wise decision. That's what we do here. Okay. So, now, you first earn the family's trust by listen to the family, build a relationship, relieve the patient's suffering, reorient the family. Closure of life business. Now, this is where what you do as your role, as a breaking the bad news. You reorient them. What is the need of telling them the truth? Whatever that we learned in the first slide, closure of life business. how it will help them, their last will, their accounts, their their bucket list and everything, hospital hopping and doctor shopping. It will help them when you reorient it. The family members will start thinking of it. Okay, so I was spending all this money, without any result. So I think I should wisely do that. Let me talk to the other family members, or let me talk to the patient. Barrier in the relationship. Reorient everything, each one by one, to the family members. This is why. So that's what I said. That if the family members come and tell you that I don't want my father or I don't want my mother to know about it, now you say you agree to collide. However, you explain and you reorient the family members and tell, we're not asking you to, or we are not pushing you or forcing you to tell the patient about the diagnosis prognosis, but why we are telling you that it is a right for the patient to know is because of these things. Let them know, because they don't know. Most of the people don't even know what is palliative care, sadly, yes. In India, people do not even know what is palliative care. So at that point of time, imagine when you go deeper into this, it is us who should explain about all these things in detail. Now, do not make this your agenda. Be prepared for failures. See, breaking the bad news can go wrong. It might go wrong. It has gone wrong in my case also. Because when, suppose like Ernestine asked, if the patient wants to know, and if we start, okay, if the family member doesn't want to know, and the family members thinks that the patient, if the patient comes to know, he'll go into depression, or he might not be able to take it. But the patient, we feel the patient is very active and the patient is positive, patient wants to know. But suddenly when we start doing it, the middle of the session, maybe the patient might get upset and they might become violent. It can happen, right? And then what happens is the family members would come and tell us, I told you in the beginning itself, this is what happened. Be prepared for failures, but you have to face that situation. You can handle that situation. That's what we have to do here. So do not make this your agenda, but be prepared for failures. It will not be a successful attempts always. It can go wrong. Now, let's talk about the spikes model, right? So, communicating bad news, the SOP. The first thing we might do is, when you communicate the bad news, make sure that your environment, the people around you, everything matters. The sound, noise, which room you're sitting, it matters a lot. It's more like a counseling session, right? So setting up the interview is the first thing. So there should be a doctor, there should be a social worker, and whichever health provider which is close to the family members, preferably the close one who is having a good relationship and rapport with the family members. And firstly, the family members. If it is family member or the patient, and the first thing as a clinician, or as a first thing as a palliative care worker, we need to understand what is the patient's perspective of the disease, how much they know about the disease. Sometimes they might itself tell you everything. We don't even have to go for the spikes protocol, because when you assess the patient's perception, the patient might tell you, they itself will tell you, okay, I have this, and it has spread it all over but they might not know the term prognosis. They might not know what is this spreading all over the body, how it can affect. So understanding and assessing patient's perception is important, which is the first thing to do in SPICE model in communicating bad news. And obtaining the patient's invitation, very, very important. You should make sure that the patient is willing to come or not. Get the permission and invitation, then giving knowledge and information one by one. Whatever knowledge and information that you have, give it to the patient. Addressing the patient's emotion, very important. And then, after addressing all the emotion, it would be different in different patients, right? Then you go for the strategy and summary. Ernestine, you want to say something?
Yes, please. I didn't get the third point, obtaining the patient's invitation. Is the patient, I'm thinking the patient will be sitting with you already.
Sorry?
So can you come again on that? Thank you.
Oh, okay, fine. Yeah. So let's go for a case study. Okay, and I want you to go through all the points that I have given here, because if we only go through the spikes model, I mean, what is a spikes model? It's not going to get you through it. So I have come with a case study, and we're going to see how do we do it. How do we break the bad news in a descriptive way? Okay, you're going to see how is it in a verbal model. Now let's say Mr. Bharat. Mr. Bharat is our patient, a 60-year-old gentleman with abdomen discomfort and weight loss in 2 months. So local GP referred to gastro at City Hospital. Now, CT abdomen has taken, there is a mass lesion in the stomach, OGD, HPR taken, carcinoma stomach. So it is identified carcinoma stomach. Exploratory lab, multiple peritoneal mets closed. So you know what is this prognosis is, right? Refer to you for symptomatic or supportive care. Patient sitting in front of you. Now, what you need to do is that put yourself as Mr. Bharat. Now I want you to read it, take 1 minute, go through all this and put yourself as, just forget about you, forget about your names, you are now Bharat. Okay? Now you need to think, if it is you, you are 60-year-old gentleman. Okay, you have abdominal discomfort and you have weight loss since 2 months. Now you went to a local GP. Now they referred to you to the city hospital for gastro. Now from there, you have taken a CT abdomen. There is a mass lesion of in stomach. Then carcinoma stomach by HPR. Exploratory lab, more scanning, found out that multiple peritoneal mets closed. Then, which means it's have already spread all over the body. Now, referred to us in palliative care for symptomatic or supportive care. Now you are sitting in front of me. Let's say I am the doctor and you are Bharat. Now, this is the patient story. The patient is coming and telling you, I have gas since 2 months. So, gas is the vocabulary you should notice. So, the patient thinks that he's having gas. Went to the nearby doctor, he gave me gas tablets, but still there was no relief. He took an x ray of my stomach. Okay? Now, I don't know anything about the stomach, but he gave me a letter to see gastro doctor at City Hospital. So, you went to City Hospital. Now, the gastro doctor did a scan, a tube test, the test inside, which is an endoscopy, to understand what is it. Now, they told me that a surgery was needed. Okay. After the surgery, they gave me this letter. So, the surgery has done. Now, after the surgery, they gave me this letter to come and see you. So, basically, the patient does not know anything about what he is going through. All he has is some papers and he knows that he's having gas. You know, okay, let's say you are Bharat. You know that you have only gas problem. Now, we are going to see the patient's insight. So the patient first says, I have gas since 2 months. Went to nearby doctor, he gave me gas tablets, but there was no relief. He took an x-ray of my stomach, don't know the result. Okay, you don't know the result. You know the x-ray has been taken, but you don't know the result. That is a fill in the blank. That's a blank statement. You don't know the result. Now, give me a letter to see gastro doctor at City Hospital. What you think as Bharat is that maybe they have given me or gave me a letter to go to City Hospital for better treatment. So this is what you know. If you are Bharat, this is what you know. Now, gastro doctor did a scan. Again, you don't know the results. And a tube test, don't know the results. Now, after surgery, my gas problem is gone. Okay, so after the surgery, one thing is the gas problem is gone. But I'm feeling more and more tired each day. Give letter to see you for better treatment. So, what is the patient's insight here? Can you use the chat box or you can say it with unmuting your audio? If you're Bharat, what do you think? Do you have hope, expectation? You know nothing about your disease. You think I had gas? Okay, my gas problem is no more. Now I'm here for a better treatment. So what is that I have? I have a hope that okay, I'm here to clear out my tiredness. so that I can go back home without any pain, hope for a better solution. But the patient does not know anything about it. Now, exactly, hopeful, expectations, hopeful, maybe false hopes they have, he has, right? Now let's see the pre-procedure preparation. What do we, if we are, now you switch your roles. If you are the doctor or you're the nurse, you are the communicator, you are the one who's going to tell him. You're going to tell him about the bad news. Now let's see. Up to date yourself on the patient's medical condition. Before you start talking to the patient, make sure that you educate yourself regarding all the documents, all the scanning reports, all the X-ray reports, all the endoscopy reports, everything, and get educated yourself regarding his disease, his diagnosis, and the prognosis. Make sure that you know each and everything about his diagram, because we cannot give wrong misconceptions or misstatement. We should be clear of that. Right, Ernestina. Yes, he thinks that he comes for a physical treatment. Please, of course. He thinks he can go back home with all the problems solved. Right? So, up to date yourself on the patient's medical condition. Allocate dedicated time for the procedure. You have to allocate a time for the procedure. Now, set the environment. Very important. There has to be enough chairs to sit. There has to be water and tissue paper. Very, very important. That's why I said in the beginning it is close to a counseling session. In a counseling session, what we do is that we put water, tissues, and everything, right? Then practice active listening. Very, very important. Only if you listen carefully, you will be able to understand what is that exactly the patient requires, the patient's requirement during the process. Now, step one. So we're going to see step one by one. Explore if patient wants to know. So we know the fact that the patient does not know anything about his disease, his diagnosis or the prognosis, both. Now, the first thing as a healthcare provider, as a communicator, we should understand whether the patient wants to know. So how do we ask? Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your disease? So you can ask. You can ask your patient whether he wants to know about the disease. So the patient might tell you, yes, I do want to know more about my disease. Now, only proceed if the patient wants to know. If the patient gives you that invitation, that's when you invite. You know, only if the patient gives you proper consent, you go forward with it. Now, give a warning shot. You're giving a warning shot so that you will understand how he reacts to it. Mr. Bharat, if it's something serious, would you still want to know? So that you're giving a warning shot, he'll understand there is something serious. Right? So, can you give me my medicines? I have to go now. You can expect so many answers in this. Maybe your breaking the bad news session will stop here entirely, because if the patient does not want to know, it will be very clear. Either they say, can you give me my medicine? I have to go now, or tell it to my children, I don't want to know. If the patient doesn't want to know, you have to stop it right there. And then the next step is you can approach the family members and go forward with it. Now, if the patient agrees to continue, if the patient says, yes, I do want to know, how do you say? Tell a story. Okay, you're making it very smooth. That's what we need to do. Tell a story of the patient to the patient from the beginning. Fill in all the blanks and escalate information as you go along. And if the patient stops eye contact, pause the story. Make sure that your eye contact is very important. All you have to do is observe the patient in all ways, in all terms, in all regards. Whenever the patient does not give you eye contact, whenever the patient looks down or gets upset, pause the story. Do not continue. Give some time for ventilating his emotions or her emotions. Pause. The patient is processing new information. Either the patient might tell you to stop, or maybe the patient is taking some time to process the information and then we'll continue. If in doubt, if you have doubt, you can ask the permission to proceed. Can we proceed? Stop where patient wants to stop. Very, very important. Where the patient wants to stop. That's what I said. It can go failure. It's not going to be a successful one. You cannot think that this is going to we can tell the diagnosis or the prognosis towards the end. No. Maybe at some point of time, even the strongest person might not want to know more. They might want to stop in between. Stop where the patient wants to stop. This is the thing you need to do. Telling a story. So, how do we tell a story? Mr. Bharat, you have been suffering from gas since 2 months. Your local doctor gave gas medicines, there was no relief. Then did an x ray. So, you are reorienting the whole story to to the patient. Now, telling the story, you are going to fill the blanks. X ray showed something like a shadow. Now, to know more about this shadow, he referred you to City Hospital. So, you are making this communication more clearer to him so that he understands it. He comprehends it. Okay? Now, I didn't know that. Of course, he didn't know it. He didn't know it. We thought he had some gas problem. He thought he is being referred to the other hospital for a better treatment. Now, you're continuing the story. In the city hospital, scan showed something like a tumor. To know what this tumor was, they did the tube test, which is called the endoscope. So you are making it very, you're telling the story very clearly so that they understand. Now, when they hear about tumor, because when we hear about tumor, it is mostly a negative word for most of them, right? Now, you might have to stop there, pause. Pause there, and then you continue. The tube test was done to see if your tumor was something like a cancer. Now you're revealing it. It's a cancer. Anything you can expect at this point of time. Do you mean to say that I have cancer? I'm sorry. Yes. Oh, you might see the patient crying, become violent, scream. There has been situation where the patient has gone running out of the hospital as well. But give that time and space to ventilator is so important. Be with that patient. Now, again pause. Because this is a very crucial time, maybe you have to give a pause to the story. Now, listening to the story is again pause and then you ask more. You get the permission. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? So expecting it that. Because after the surgery, he's not having any gas problem. So he thought, okay, cancer is fine. I accepted it. But they had operated and removed my cancer, didn't they, doctor? How would you answer to it? I am sorry. When they opened up your tummy, they found the cancer had spread all over. They could not remove it, Bharat. They lied to me. You're going to see ventilating their emotion. Now, allow emotion ventilation during the time. Again, they might get angry. They say, they lied to me. They didn't tell me this. They lied to me. All you can do is trust me. Just be with the patient. Do not say anything or something. Just maybe a pat or maybe a gentle touch with the concern. Your presence is what they might need during the time. Because whatever you're going to say, that is not going to make sense. You cannot say it's going to be okay. You cannot say it's very common. Nothing you can say during the time. Don't say something because there are situations where your presence only matters. You don't have to say anything. You just need to be there with the patient. Doctor's alert is here. What if the patient tells you how much time do I have, doctor? So if it is you can use the chat box and tell me if it is you. If your patient asks you how much time do I have, how will you answer? Can you say? Can any doctor say? Can any hospitals give an accurate period that okay, you will die in 3 days, you will die in 5 days? Okay, something is wrong here. You can use the chat box. Yes, you can use the chat box. How would you? I do not know. Honest answer, very good. Yes, there was a time when I also didn't know. I didn't even know. Does anyone have another opinion? This nobody can predict that. Yes, we are not God. We are not the ultimate creator. We are not the person who can say. Do not really, because giving a time period can cause more anxiety. The honest answer is, how can we give a proper time limit? We cannot say 5 days. We cannot say 10 days. We cannot say 1 year. We cannot say 2 years. We cannot do that, right? Or we can do it. We can alert them, right? We can alert them. We can alert them. So, when if you have to encounter with such questions, how much time do I have, doctor? There will always be a reason behind this question. This is a thing we should understand. There's always a reason why patients usually ask these questions. Why? Can you imagine? Can you say why? Why people usually ask this? How much time do you have? Can you tell me the reasons why? What could be? Exactly. Excellent. The future so they can plan. So maybe the answer they're expecting, maybe it is not the days, the number of days or the number of years. Exactly, to put things in place. They want to know if it is very short. They only want to know how worse his condition or her condition is so that they can plan accordingly. This is where you are helping them. The answer might not be the days that they want to hear. The answer might be something else. So, what you need to do? You need to ask, why do you ask that? Why do you ask that? My daughter's marriage is fixed after 6 months. Should I arrange it earlier? Now you see, you need to explore. Now, this is where we can help them. How much time do I have, doctor? Again. Now, again, you go for this question. Why do you ask that? Why did God do this to me? Now, this is spiritual. We talk about the total pain. We talk about physical pain. We talk about social pain. We talk about financial pain. We talk about spiritual pain. This is the spiritual pain. Now, you tell me if the patient comes and tell you, why did God do this to me? Do you really have an answer to say this? What would you do in this case? This is spiritual pain. If a patient comes and tell you, why did God do this to me? How will you handle this question? And you can use the chat box. How do you answer that? I do not have an answer. Honestly, there is no answer to it. As I said, spirituality is individual, it is personal. My way of spirituality won't be the same as Arya's spirituality. Some people find it spiritual. Spiritual is what? It is being in a complete form, which gives you a hope, which gives you relief, which gives you content. You do something. I go to temple. I go to temple and I do archanas. I do rituals. That way I feel spiritual. That's a connectiveness between you and something else. You feel good. You feel connected by doing something. My way of spirituality is nature. I want to go for a travel. I want to go into a forest. I believe that I'm connecting with the nature. That is my way of spirituality. So if someone asks you why did God do this to me, you don't have an answer. Stay silent, because honestly, you cannot answer to this question. We cannot, in yes, believing in God is a spirituality, is one form of spirituality, but it does not have anything to do with religion. Spirituality does not have anything to do with the religion. For some people, going to church is their spirituality. Having connectiveness with Jesus is spirituality. They find hope, they find happiness in that. They feel complete, right? So you cannot question anyone's spirituality. And for this question, we cannot answer. We cannot answer. We can only simply stay silent and be with them. Your presence matters the most. Now, finishing the story, once the emotional reaction has subsided, ask for any further information that the patient would like to know. You can ask if you would like to know more. Give honest, clear, and precise answers, or not lack of information if that be the case. Like in case, if you do not know about something, suppose the information that you are revealing or you are telling them, if you do not completely know, you can tell whatever you know. Lack of information is fine, but do not give any. It should be honest and clear and precise. Okay. Practice management through participatory decision making. Now, they might not know what to do next. Now, you have to be there and participate in the decision making process along with the family members and the patient. You can give suggestions. Okay, you could do this, you could do that, so that you're helping the other family members or the patient to move forward. Because in that situation, it might not be easy for them to think of what to do next. They might be broken down into pieces listening to all this about the disease. So what you can do is then help them by giving them suggestions and advices, and let them take it. Let them take it and let them decide what can be done next. But you be there along with the decision making process. And do not give false hope. Do give achievable hope. No false hope, give achievable hope only. Okay? So let's say managing anger in the clinic, it is not a law and an order situation. You know, it's like the most important thing is, while doing it, make sure that your mental health is okay. For example, imagine that you had a very big fight at your home with your spouse, with your children, with your family members. It's quite normal, right? And your mood is not okay, your mental health is not okay, you're upset. And when you enter the hospital and when you're about to give a pollution or a breaking the bad news process, make sure that you are in for it. Make sure that you're fit for it. If your mental health does not help, because you have to be in your full consciousness when you do it. Because you're going to address each and every emotion of the patient and the family members sitting opposite to you. Now, your mental health matters. It does matters a lot. And if you're not able to do it, it's completely okay. You can hand it over to someone who can take up. Make sure that. And also, sometimes after this, you might also need a space to vent out. You can find the proper places or proper people you can go and do it. You know what I usually do after for venting out my emotion? So there is I don't know, it's my way of venting out. I don't usually go and cry and tell people, oh, this happened, and I cry and vent out my emotions. No, I don't do it. Sometimes I self talk. I tell myself, and I believe that I have me, I have myself. You can't expect people to be with you most of the time. Sometimes you'll be alone and you have to deal the situation alone, right? So what I do is, there is one restaurant, one cafe, which is about like 5 to 6 kilometers from where I work, and they have special, different activities. They have already set up drawing pencils, puzzles, and books, different activities. So what you can do is that you can go to the cafe and you can order your favorite cappuccino or whichever food, and you can do these activities. So when I am not okay, like for example, when I do the collusion breaking part, if I be any part of the collusion breaking process, and if that hits me mentally very worse, if I go mentally wrong after this, I would go to the cafe in the evening, I would sit there and take the drawing part, I draw. I draw and I draw out all my emotions there. I color it, then I have my favorite coffee, I eat something which is my favorite thing, and I went out in that way. It might not be the same way that you do, but this is one way of it. So you also have to find out your own ways of venting out your emotions, because in the end, you're also a human being. Your emotions matters as equally as patient, because you're putting yourself in their shoes. So obviously, if you put yourself in other person's shoes, you're going to go through the same emotion, right? Anger, high energy consuming, it is a negative emotion. So, yes, we need to totally understand that. Now, suppose if any angry situation, like for example, if the patient comes and scream at you, they call you bad words, they lie to me all this time, and they throw all the papers away or everything, how do you deal with it? Do you fight back with the patient or fight back with the family members? How do you deal with that? No. It's stay calm. Great. Stay calm. So I think we also need, because we know the fact that this anger will come down. It will come down. They will come down once they show their anger. Once they show it, it will bring their anger might come down, and you have to wait for that. Stay calm and wait for it. Okay? Just your presence matters. Now, your body during the pollution breaking the bad news, your standing position, it the other person should not feel that superiority, which is very important. When you cross your legs and sit in a big chair and talk, that will not build a trust, that will not build a proper relationship with the patient or the family members. Always stand in the same position that shows equality. Okay, posture slightly bent forward, which shows respect. Hands in front shows no threat. So this is how usually we sit, our body language during the session. I mean, this is the body language that we usually do it, not even just in breaking the bad news, but also in case of seeing the consulting with the patient and the family members. This is the way we follow. Your eye contact, your face shows you're confident, because only if you're confident, the other person will tell you everything, like what we discussed during the last session. Serious face, if you give a serious face, it shows you're taking this seriously. No. And nodding of head, allowing ventilation. So make sure you're not sitting still or you're not standing still. Make sure that you nod your head in between so that you're listening. The active listening is happening, is what they understand. Okay. Now, allow ventilation of ankle. This is normal. Okay. And they calm down, they say they did not tell, and after that they would not, we should. They might tell you in words that they will understand. And then once the high ankle is diffused, I want to know more about this. Can we sit down somewhere and talk? And then there they might want to know about the prognosis. I want to know more about this. Can we sit down and somewhere and talk? Now, sit down and allow ventilation. Continue the positive body language. Find out the story. Resolve the matter as best as possible. And then they will eventually tell you, sorry, don't feel bad. That's why I was so angry. I couldn't let in. I couldn't control my emotions. So continue this and ending it well. Okay, ending it well is important. Offer a solution if there is a solution. If there is not a solution, do not offer one. So you can offer. Maybe that's what I said. The moment we disclose the diagnosis or prognosis, their thoughts might go somewhere else. It would be puzzled. They would not know what to do next. They would be in a completely, broken down situation, and then you offer them a solution so that they can think wisely and take a decision. Offer an apology if it's merited. Do not give an insincere apology. I'm sorry. No. Thank you for bringing this to our notice. We're very sorry you had to experience this. This has to be sincere. This is how you end it well. Now, these are some of the points that you can take home. Listen to the family to manage collusion, very important. Your role is a facilitator of information. You're facilitating the information so that the patient decides how much they want to know, if they want to know. Ventilation of emotion is actually a therapy. It is not a waste of time. It is never ever a waste of time. Pausing in between and letting them ventilating the emotion is actually a therapy in counseling. Non-confrontational active ventilation of anger is an easy skill to master. Because once if they don't show emotions is where is going to make it very difficult. Sometimes they won't cry, they won't show emotion, they will be sitting still, they will not show any anger, they will not show emotion, they will not cry. This usually happens when the patient and the family members has a very close and strong bonding. But make sure that they have to ventilate, they have to cry, they have to show their emotions, otherwise we won't be able to help them. In that case, maybe we need more sitting, we need more counseling sessions so that until they show their emotions and finally we can help. So yeah, so this is all about pollution breaking. I hope this helped you. And yes, if you have any doubts, you can use the chat box. If you have any concerns, Ernestine, I think you had some concerns in between. I hope I've cleared that. If not, you can use the chat box and ask me. In between, this is my mail ID and this is my official phone number. You can note it down. The communication process and whichever related to our class. If you have any queries, if you find difficulties in your practice in future, you can contact me. You can either send me a mail or you can throw a message in WhatsApp and ask me. I can help you. So, any doubts, anything?
Please unmute yourself and ask the doubts.
So, Ernestina, I think you've asked like if the family member did not like they don't want to know, but the patient wants to know. Obviously, if the patient wants to know, it is the right for the patient to know. If the patient says, I want to know, you have to say. You have to say, and you have to convince the family members that if the patient wants to know, we cannot do, we have to tell the patient, and then you reorient them politely. See, this is not going to end up, in a mess, trust me. This is only going to help the patient. Let me tell you or let me explain you how. And you explain and reorient everything about the hospital hopping, all these things to the family members. And then take their concern, okay, and then they will eventually tell. And then eventually they'll tell. And then if some family members is so stubborn that no, I don't want, talk to the patient. Tell the patient that I know the fact that you want to know about the prognosis and the diagnosis, but your family members are not willing to do so. Maybe you can provide a space where the patient and family together can talk and take a decision. That can also happen. Right?
Thank you.
Yes, Ernestina. So I hope it helped you, the session breaking the bad news. Is there anything I can help more?
There will be some doubts. Please unmute yourself and clarify it.
Also, you can tell about the presentation, I mean the class, so that any place where I need to improve, because it's not like a one-way thing, it's a two-way. I have a lot of things to learn from you as well. You're working in different firms, and obviously there's so much that I have to learn from you. So maybe I accept feedback from you as well. Anywhere, any place where I have to improve.
Yeah, please, let me find out about this. I observed a palliative care team when they wanted to, was it breaking? I don't know that time whether it was breaking of the news, but the man was on the ward, and then the team met with the family in a room, and then they went through the session. Is that what is supposed to be? I don't know what happened, but that's what I saw.
Sorry, can you make it once more? Can you repeat it?
I observed a scenario
Okay.
where the palliative care team met with the family
Family, okay.
in a room,
In a room.
and then the patient was on the ward.
Was in a ward. Okay.
Yes.
Hmm.
I don't know. Is that okay?
Yes, yes, obviously, as I said, when the patient is in the ward and you take the family members into a room which is silent, which is not noisy, and yes, obviously, you can do that. You can do a communication inside the room with the family members, and that's how exactly we come to know what we are supposed to do next. Yes, that's fine. We do that. We do that many times. Like in Pallium India, we have rooms. We also have EOL room, end of life room. You know that? Most of the people are so scared to get inside, but the end of life care patients were usually put inside that room. It is a very ventilated AC room, very peaceful room because our purpose is to give relief to them, make them comfortable until they leave the world. Okay, so during the time we call the family members to another room when the patient is inside the ward, inside the room, in the EOL room. But we make sure the patient is not alone. We make sure that we either keep another social worker or another nurse in front, towards them because he's in an end of life care stage, right? We might need someone to stand with them. We don't keep them alone, or we don't keep her alone. We'll ensure that someone will be accompanying him. On the same time, we'll be having a discussion with the family on the other room. We do that.
Okay.
Hope
Thank
I
you.
have answered to your question. Yes?
Somebody else has any doubts?
Feedbacks? How was the session?
Please feel free to open up.
Candice, how was the session? Please respond. I'm expecting it. I think this is the last session with you all. So we might not. Thank you, Premlata.
Okay, then we will move on with our case presentation. If there is no more doubts. Okay. I think Ernestina is going to, I am inviting Miss Ernestina Amma to present the case. I will share the screen. Please read out the case, ma'am. Yeah, I hope everybody can view the screen. Okay, start reading it, Ernestina, please.
Okay, thank you very much. The patient details, a female age 52 years with end-stage cervical cancer. This is a 52-year-old petty trader presenting with postmenopausal vaginal bleeding, foul smelling discharge, and pelvic pain. Physical examination and diagnostic imaging confirms stage 2B cervical cancer with local extension but no distant metastasis. Per the history, the patient is a known hypertensive but is well under control. The social history, the husband is a laborer. This female 52-year-old has 4 children, 3 males, 1 female. And the female is the one who is supporting the mother. So she is the caregiver. During consultation, the patient sent the daughter out to buy water and requested that the team does not disclose the diagnosis to the male children also, as they are fragile. Next, please. The presenting complaints were abnormal vaginal bleeding, which is postmenopausal, and then happens after sexual intercourse. There is pain in the pelvic region, increased discharge, which is watery, sometimes bloody, with foul smelling. Pain during sexual intercourse. There is pain at the back and the leg. The patient also complains of fatigue, weight loss, and then loss of appetite. History of illness. The patient has vaginal bleeding that started about a year ago with some occasional spotting, which became heavier and more frequent, with foul-smelling vaginal discharge, pelvic pain, which is dull and constant, occasionally radiating to the lower back. There is pain during intercourse, which is dyspareunia, fatigue and loss of appetite noted over the past few weeks. When the physical activity happens, it increases the bleeding, but the patient has a history of irregular menstrual cycle with heavy bleeding. So these are some of the examinations. With abdominal examination, there was mild tenderness in the lower abdomen, but no palpable mass. During pelvic examination, there was visible cervical lesion with irregular borders, about 3 centimeters in diameter, moderate bleeding noted during examination. Vaginal wall appears normal. Palpating the lymph nodes, there are bilateral inguinal lymphoadenopathy, but it's non-tender. Pelvic ultrasound, we have enlarged cervix with irregular echogenicity suggestive of malignancy. No evidence of agenesis masses of free fluid. MRI pelvis indicated cervical mass measuring around 4.5 centimeters by 3.2, extending to the parametrium bilaterally, but not involving the pelvic wall. There is no evidence of distant metastasis. Biopsy results indicated squamous cell carcinoma of the cervix. Treatment and significant investigation. There is blood transfusion due to the anemia, pain management with NSAID, and when it becomes severe, opioids are required. Oncology referral, which was to the gynecological oncology treatment for planning. Then under the definitive treatment, there is radiotherapy, and then brachytherapy, which included internal radiation to ensure localized treatment of the tumor. Adjunct care, there is nutritional support to address weight loss and appetite, and then psychological support to address anxiety and providing coping mechanisms. On medication, we have controlling the bleeding. So the patient was on tranexamic acid, 500 milligram per hour 3 times a day for 5 to 7 days. On pain management, it was brufen 400 milligram 8 hourly as needed for mild pain, and morphine 5 to 10 milligram every 4 hours for severe pain. The chemotherapy agent was cisplatin 400 milligram intravenous weekly for 6 weeks, administered concurrently with radiation therapy. The adjunct medications, ondansetron 8 milligram orally every 12 hours during chemotherapy to manage the nausea. Omeprazole 20 milligram per us daily to prevent gastric irritation. Multivitamins daily to support the overall nutrition. Iron supplements, ferrous sulfate 200 milligram orally once daily to address anemia. Then for anxiety and depression, it was given lorazepam 0.5 milligram orally as needed. Up to twice daily for anxiety symptoms. Next slide, please. Psychosocial aspects, the psychological impacts. The diagnosis of cervical cancer has caused significant anxiety and emotional distress, with patients expressing fear about prognosis and concern about their family's future. The coping strategies relies heavily on their spouse for emotional support because they are really attached and has expressed willingness to engage with a counselor. In terms of social support, financial constraints, because he's a petty trader and the husband is a laborer, have limited access to care in the past. Assistance programs and social work referrals are being arranged to ensure comprehensive care. In terms of culture and religious consideration, patient identifies with the faith community, a strong Christian, and has expressed interest in involving her religious leaders for spiritual support. But then there is the issue of collusion, not informing the male children, even including the caretaker. In terms of psychosocial aspects, management plan, psychologically, do psychosocial assessment and counseling to address anxiety and stress, and to refer to clinical psychologists if needed, because in our country, we don't have a lot of the psychologists. So that's why they would not start it. Then introduction to support groups for patients with cervical cancer to provide peer support. Explore with patient and daughter separately why the collusion and address them. And then you can hold family meetings. Social work assistance with assessing financial aid programs and insurance resources. Then facilitation of transportation services for treatment visits. Spiritual care, collaborating with chaplaincy service to address their spiritual needs. Then in terms of ongoing monitoring, there will be regular follow-up to assess psychological and social progress and make adjustment to interventions as needed. The medications, syrup morphine 5 to 10 milligram 4 hourly, tap tranexamic acid 500 milligram TDS times 5 days, and then tap fesolate 200 milligram daily. The main concern was about the severe pain, bleeding, inadequate knowledge of actual problem, anxiety, loss of employment or financial security, collusion and breaking bad news to bring entire family to the same page. So this is a summary. A 52-year-old female who presented with locally advanced cervical cancer on syrup morphine 10 milligram 4 hourly, informed of her condition, thinking about loss of independence in daily activities. There is depression, anxiety, social isolation, and dependence on the caregivers, and then the collusion. So points for discussion. How do you break the news of the diagnosis to the woman and her family? Because how will we prepare and set the scene for breaking the news? How will you start the conversation? And what will be some of the questions we could ask? Does this patient need palliative care? If yes, why? If no, why? How do we deal with the emotions and denial if they happen? And what do we need to achieve from the conversation in terms of the nurse? What do you hope to achieve? And then the patient. Then how do we deal with the collusion in our practice? So these are some of the questions brought up for discussion. Thank you very much. So can we start the discussion?
Based on what we discussed in breaking the bad news, I think you itself can go with the discussion. Okay, it would be easy for you to answer because we've already seen how do we break the bad news. Go on.
Can you come again, please? I didn't. Please, what did you say?
Oh, you can. No, I said we have already discussed how to break a bad news and we've seen a case story. So I think it's going to be more easy for you. So I think you all can come forward and discuss how are you going to do this with taking the examples of what we discussed before. Go on. Yes. Stage is yours. So how do
So
you
do I answer the questions? Is that what you are saying?
Yes, all of you in this can start answering the questions. Come on, like everyone.
Okay, so how do we break the news
So
of the
can
diagnosis?
I ask Ernestina,
Yes,
how do
please.
we first go about, because we have to get her consent, yeah, to discuss her condition with her family? In the first place, I'm thinking she doesn't even want her daughter, who's her
Yes.
caregiver, to find out.
Yes.
So I'm thinking first we have to figure out a way to get her to be okay, to get even her daughter to find out. And then maybe that will transfer to her boys, to convincing her to get consent that we could even tell her daughter and then her boys. You know what I mean? Because
Yes,
we 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 don't want her to feel like we are going against her wishes, but at the same time we do want the family to understand what is happening to the matriarch of their family. So, and
yes,
I'm sure she's a pivotal role in that family. So I
yes.
think in the first place, we have to get kind of in her mind to figure out how we can get her to be okay with us even discussing this with her family.
Yeah, thank you very much, Louis. I think I will go for that also. Thank you. Because she's trying to protect, like we saw in the presentation, protect the loved ones. But then since they can also be supportive in terms of the care, I think we all have to come to the same page and then assess, find out the reasons why she doesn't want them to know. So we get more details about why, and then together, as palliative care nurses or the team, we can discuss how together we can bring those two boys in, even including the person who is providing the current care. Thank you very much. So how will we prepare and set the scene for breaking the news? I think if we go back to what we have been taught, using the spike, I don't know if that will be right.
Yes, sir.
Using the spike model.
Spikes model, yes, perfect.
Yes.
Can go ahead
Yes.
with it.
Yes, using the spike model, setting the scene, getting the items, the water, the tissue, the cyst ready. I think that will help. And then assessing the patient's perception and what they want to know, who to be involved.
Exactly. Right.
I think that will help. And then I think the posture, what we just ended with. So the posture, the eye contact, all those ones will matter to let the family build that trust and confidence in us, and then we can move from there. Any other? How do we deal? Does this patient need palliative care?
Well, please have a discussion. Yesterday we had a good discussion.
Exactly. But there is all the energy gone. So yes,
I
does
think
this patient need
1,000.
palliative care? Of
Well,
course.
I think the patient definitely needs palliative care. I mean, everything that the patient has going on with the bleeding, the pain, the depression, the anxiety. I mean, this is the ideal candidate for palliative care, and the palliative care of a multidisciplinary team where you don't have just, oncologists dealing with the obvious diagnosis, but she has depression, she has anxiety. I mean, I'm sure she's worried about her future and the future of her family without her. And you know, she definitely needs and the fact that she doesn't even want her family to know lets us know exactly what, mentally she's going through. And then on top of that, I'm sure she's in a lot of pain. So she definitely needs palliative care.
Yeah. Thank you very much to ensure quality of life and looking at the holistic care. It means that this patient really needs palliative care. I don't know whether if we can look at the collusion. How do we deal with the collusion, which was part of what we discussed this morning? How do we handle the collusion? So the woman herself has set up the collusion. That's why she's sending the daughter away and then telling us that we should not get the two sons involved. How do we deal with that from what we have been taught this morning?
I think that would be the ideal time to talk to her and get, as we said earlier, speak to her and figure out and assess why she doesn't want her family to know. Because although she sent her daughter away, we can now speak to her privately and assess that part of why she doesn't want her daughter to know. So maybe even by the time the daughter comes back with the water, she may be on board
Mm.
to letting her daughter know who's a caregiver. But as much as she sent her daughter away, it will be the ideal setting for us to assess and then come up with some sort of plan.
Okay, thanks, Louis. So it means, are we going to assess the 52-year-old whilst the daughter is away? Do we do that first before the daughter comes? That's a question to faculty. I just want to find out.
So, Ernestina, is that a question for me?
Yes, please.
All right. So you're asking, can you repeat the question once more?
The question was, do we start the discussion whilst the daughter is away to find out why the collusion?
I think when the daughter is away, because we don't know the time when she comes back, because the conversation is going to get abrupted in between. So, as we said, the conversation must be very clear and precise. And so, we are setting up an environment where we're going to assess each one of their perspective about what they know about the disease. Sometimes, in some cases, am I audible, Ernestina?
My line is breaking and I can't really hear it very well. It's not very clear.
What about now? My
Yes,
audible?
yes, thank you.
Our whole intention is to make the communication very clear, right? So please feel free to tell me if I'm wrong, or if you think that I'm wrong, it's completely fine, because everyone will be having different opinions, right? So I do think that we need to set up environment for each one of them and see what is each one of their perspective about the diagnosis and the prognosis. In some cases, the daughter, maybe the mother saying, please do not tell to my daughter, because she's the primary caregiver. Since she is a primary caregiver, we don't know, there are chances are high that she might already know what's going on. Maybe she is keeping silent because she doesn't want to hurt her mother. So for that, it is very important to know everyone's mind, right? So the thing is, if we do it when the daughter goes inside, and when the daughter goes to take a cup of water, the time is very limited and the conversation might get abrupted in between, right? So we might not be able to have a fruitful conversation with the patient. And the another problem might come is that when we do it like a secret thing, maybe they think like, okay, when the daughter comes, you're stopping it. It might give the daughter a benefit of doubt also. "Whoa, what is it? What is it they're discussing? I mean, is this something serious?" So we need to tackle this very smoothly, and that's why we have this protocol. That's why we make it in a setup and environment, and we make sure that we get all of their perceptions about the disease and the prognosis. And yes, as Rainy said, it is equally important to understand from the mother's opinion, like with the mother's statement, why is she telling not to tell the daughter? There must be some reason for it. There must be some reason for why she's, in some cases, I have had a similar incident in which the daughter was about to have her board exams, her main exams, and the mother knew everything. Mother did not want us to tell this to the daughter because she needs to attend the exam. In that case, the reason is valid. Maybe we might have to go saying okay with it, right? It's not because of any other reasons. So yes, at some point it is very important that you need to understand why is she telling that, and then
Oh.
you decide whether to tell or not. And initially you said, like at some point of time, maybe we cannot complete the process because some patients, some family members come and tell us that please do not tell my father, because they might be having some history of cardiac arrest, some history of heart attack, some history of cardiac issues, some issue of high blood pressure. So there would be valid reasons why the family members come and tell us not to say them. But also we can find out alternative options where we are not telling this suddenly. We are taking it as a process, maybe day by day or one by one session, and then we make it understand to the patient. And some cases, the patient's heart is so fragile. Because that has happened. We have started the collusion breaking, and then he started having BP and palpitation, and then we stopped. And then at one point, we thought we're not telling them. In some cases, a person with brain tumor has no memory, nothing. He's in coma. Is there any point in telling the patient breaking the bad news? No. At some point, there would be reasons why we should not tell. So it is important first that you need to talk to everyone, not in the absence of like when the daughter goes inside and take water. Maybe why? Because why I say no? Because the thing is, the communication might get abrupted, might get disturbed in between. So it should not get distracted. Your communication should be smooth and clear. Do you agree with me?
Yes, because for this case there was a case like this where when the one of the sons was informed, she was also admitted.
Um,
So that, like you are saying, so we have to know when and how to
exactly.
break the news and then get them involved, because it led to admission of one of the sons once he got to know the news.
But in this case, does that mean that we probably may have to take the patient elsewhere? I mean, take her away from the home just in case, if we are trying to prevent, a daughter coming back or a son coming into the room, or does that mean we may have to get her in a clinic
Maybe what we can do is
setting?
that there will always be a team that handles the situation. Meanwhile, maybe another team member can have a conversation with the girl. The other time, maybe we can have a conversation with the mother. Or otherwise, if the kid is kind of small, or maybe you can have an interactive session, give an activity or play with them. So eventually, they will talk to you, build a trust, so that you can collect or you can understand the perception of the girl, the child. Meanwhile, the other member can talk to the mother, right? So we can plan that way.
Then after that, can we bring the two together? Would
Yes,
that be feasible?
if it's needed, yes. We had a scenario where we had to bring a son and a father together because they had communication problems. Both of them didn't want to hurt each other, but the actual problem was lack of communication. And when we brought them together and we gave them a space to interact, a lot of things got clear. At some point of time, it's us, we need to find out what we're supposed to do on the process of breaking the bad news. Now, it's like you're not making the decisions prior, you're making the decisions up to date because it might change in between in the course of doing it. So, yes. It's like sudden decisions that you have to take at that point of time. What do you think? Okay, what's good for the patient? What benefits the patient and the family? So, in that way, you can think. It's a
Thank
learning
you.
process. It's a learning process for all of us.
Thank you.
So can we close the discussion? I think it's already time. And please feel free to use my mail ID and my phone number. You can take it. Or if you want, you can contact Arya and take my contact details and feel free to ask anything because we all are trying to spread palliative care, spread the wings across the world. And we need to make sure that everyone gets palliative care. It's their right? People should not suffer because of lack of knowledge about palliative care. So feel free to discuss. Yeah, thank you so much, and I think it was a really great session, interactive session with you. Hopefully to see you somewhere because we all are be working in palliative. So hopefully, yeah. Thank you.
Thank you very much. And
Thank
thank you
you.
for the opportunity.
Thank you, Ms. Devika Rajendran, for giving an insightful session on breaking bad news and collusion. And I want to give my special thanks to Ernestina Amma. Such a brilliant case it was. I thank you for sending the case so promptly. And I thank all the participants for your active participation. We'll see in the next day. Till then, bye.
Thank you very much.